Tell us something more about AVN.
Avascular necrosis, femoral head is one of the most commonest areas that we get avascular necrosis. So once the blood supply is obstructed, what happens is that the bone cells die or necrose. This particular condition occurs in younger population, mostly between 20 and 40 years of age. The another interesting factor is that this is a silent disease.
Voices shaping the future of medicine. Stories, knowledge, experience. More for life.
Good afternoon. This is Mohan Nair. And on behalf of Project HEAL, we have a very interesting discussion today on avascular necrosis, popularly known as AVN. We all thought that hip problems has got largely reason, aging being the main reason, but we find that young people also have a lot of hip problems, and we saw that quite rampant during the COVID era. So today we have with us Dr. Jikku, orthopaedic surgeon from EMC Hospital, Kochi, to take us through the understanding of AVN, what kind of patients come, and so on and so forth. So I start with my first query, doctor, is tell us something more about AVN.
Okay, so let us start with the definition. So, avascular necrosis is bone necrosis, that is bone cell death, secondary to avascularity, that is interruption of blood supply to that particular tissue. So, coming to the hip is a ball and socket joint made up of the acetabular cup and the femoral head. And bone, as it is a very dynamic, viable, living tissue which depends on the blood supply for its survival and nourishment. So, avascular necrosis, femoral head is one of the most commonest areas that we get avascular necrosis. This is because of the unique blood supply anatomy of the femoral head.
Okay.
So, in the femoral head, the blood supply is derived from an arterial circle at the intertrochanteric region, which is much lower down than the head. And from that arterial circle, retinacular vessels climb up underneath the capsule and reaches the femoral head and supplies the femoral head. So this is very prone for obstruction. There are multiple medical conditions that can cause obstruction to this particular blood supply. So once the blood supply is obstructed, what happens is that the bone cells die or necrose. So this necrotic bone cells occupy a segment of the femoral head, and this area ultimately gets resorbed and it actually goes to a cavitation, or it becomes a cavity. Inside the femoral head, there will be a empty cavity. And when the patient walks and weight bears on the femoral head, this cavity collapses or fractures, and this leads to asphericity of the femoral head. That is, the femoral head loses its spherical structure, and that increases the friction between the acetabular cup and the femoral head, and this lead on to arthritis. Interestingly, most of our belief is that osteoarthritis of the hip occurs in older population. This particular condition occurs in younger population, mostly between 20 and 40 years of age. And the another interesting factor is that this is a silent disease. Initially, the symptoms are very less, and once the symptoms sets in, the head already is collapsed and it is non-salvageable. If you can detect this disease early enough, you can do surgical procedures to prevent collapse and prevent arthritis. But once the femoral head collapses, hip replacement and a replacement procedures are the only options left.
Doctor, you have some interesting cases or interesting case to discuss, to speak more about this.
Yes, I do have one case. I just want to go through this particular case. So this is a case that I did about 5 years back. This was a 24-year-old gentleman, a manual laborer. So basically, this is a Bangladeshi foreign worker. That time I was working in Singapore. So he presented with both hips severe pain. He was barely able to walk. He was walking with a walking stick with a lot of limp. He had more pain on the right hip and minimal to moderate pain on the left hip. And basically, like there was severe restriction of movements on the right side with some amount of shortening of the limb on the right side, and on the left side there was the movements was limited only at the terminal range of motion. So basically, let me go through this case. So this particular case, this is the X-ray of the patient. This is actually shows bilateral AVN of the femoral head. On the right side, you can see that the femoral head is collapsed. There is a sclerotic or hyper dense area in the femoral head with the collapse of the femoral head. And on the left side, on close observation, you can see a sclerotic area, but the head is maintaining its sphericity. So this is a very critical, this particular case is very interesting in the fact that one hip, the AVN has led to the collapse of the head, and on the other side, although the AVN is there, the head has not started collapsing. So here you can very well on the right X-rays, on the right side picture, you can see the collapsed right hip, and on the left hip you can see the lytic area with a sclerotic edge, but the head is maintaining its sphericity. So whenever the head collapses, the only viable option in AVN is head sacrificing surgeries or head replacement surgeries, which we totally call it as total hip replacement. But before the head has started collapsing, in this case on the left hip, we can still preserve the head by doing procedures to improve the vascularity of the head and do some procedures to improve the bone regeneration, do using like bone grafts and biologic materials to fill in that cavity. So I will go through this case, so which you will find it interesting.
Sure.
So in this picture, you can, our plan was to do a right total hip replacement as the head has already collapsed there. And on the same surgical sitting, we were planning to do the left hip, which we were planning to do a head preserving surgery, which is called as core decompression and bone grafting. Let me take you through this procedure. So this picture shows the acetabular cup in place. We did the right side first. We did the right side total hip replacement first. This picture shows the acetabular cup in place, and we can see the yellow needle, which is a bone marrow aspiration needle, which we actually pass through one of the acetabular cup holes into the iliac wing. This is to aspirate bone marrow, which will be later used to prepare bone marrow aspirate concentrate, which is by centrifugation. So about 50 ml will be aspirated. We centrifuge to about 55 ml. That will be rich in stem cell. Bone marrow is rich in stem cell, which is osteogenic. That is to make that is potential to make bone, which will be using later on onto the left side hip.
Is this popularly called BMAC?
Yes, it is called as BMAC, bone marrow aspirate concentrate. So this has got multiple uses. It can be used in arthritis. It can be used in arthritis of the knee, early stages. It can be used in tendinitis of the shoulder. It can be used in tennis elbow. It can be used in plantar fasciitis. There's a lot of indication for BMAC. These are generally stem cells. So stem cells are like the monoclonal cells where when it is exposed to the correct environment, it can go to different lineages. So if it is required to produce bone, the stem cell can be changed to bone. If it is needed to change to cartilage, it can change to cartilage. That is the unique property of the stem cell. So this is one thing that we did. Usually we aspirate the BMAC from the iliac crust, that is from the top of the iliac bone. But here, because as the cup is there and the hole is there, we actually made the hole. That was an innovative thing that we thought of. We aspirated through one of the screw holes into the iliac wing, and we aspirated 50 ml of bone marrow. On the right side picture, you can see the excised femoral head, and we gouged bone, cancellous bone, which is called as what is it called as? It is called as red gold in orthopedic practice. It is so precious. That is the best osteogenic substance that is available. That is the scooped out cancellous bone. So that particular femoral head, we removed the bone graft, and that particular cancellous bone graft also we would be using later on the right hip when we do the hip preservation surgery on the right side. So that's the story on the right hip, straightforward, uncemented, total hip replacement with a uncemented acetabular cup and a uncemented femoral stem with ceramic on polyethylene articulation. So that was what was done on the right hip. So we proceeded with the left hip. And in this picture, you can see me preparing the fibula strut autograft. This is a cadaveric autograft because I was in Singapore, it was freely available there. So you can actually buy it from the shelf. And here you can see me preparing it to the dimension. So basically, I prepared it into a 10 centimeter strut to a 9 mm diameter strut. It is a fibula strut that will give support to the bone preserving surgery when we do on the left hip. So you can see me preparing, and you can see me measuring the graft there. So in this picture, this is the X-ray view where we put a guide wire from the outer aspect of the upper femur into the center of the necrotic area on the left hip. And on the second picture, we can see a tunnel being made over this guide wire into this necrotic region. And here in this picture, you can see us putting a curette and scooping out all the necrotic dead bone from the left hip necrotic area. And on the second picture, we can see a bone burr we used to take out all the bone. So basically, the whole of the necrotic cavity, which is a dead cavity which is filled with very sclerotic bone at the edges, we need to scoop out everything. So that is a time consuming process. You need to take off all the dead tissues from there, from the outer end of the upper femur into the head. So in this picture, the prepared BMAC, the first picture, we can see the prepared BMAC we inject into the cavity that is formed. In the second picture, you can see we putting a cannula into the cavity, and we are filling the bone graft that is taken from the femoral head into the necrotic cavity. So you are packing the cancellous bone graft taken from the femoral head from the right side. So this is the X-ray picture where we can see the cannula into the necrotic bone, and we are punching the cancellous bone into the necrotic tissue, in the necrotic cavity. And this is the X-rays that we can see. The right side, as I told, is the straightforward uncemented total hip replacement. On the left side, you can see the fibula strut, which actually gives the support to the bone graft and the BMAC that we put into the cavity, and it gives a support to the osteogenic and the bone, the good stuff that we put into the cavity to fill the cavity, and this fibula strut gives the support to that. You can see the fibula strut going all the way to the subchondral region. So when we do this core decompression, it does another thing. So basically, once we make holes into the femoral head, this actually decompresses the femoral canal. So one of the causes of avascular necrosis is intraosseous hypertension. That is, the pressure inside the bone increases. So basically, the core decompression at its as a standout, as a single procedure, can cause decompression of the bone and can improve the blood supply. So with this case, why I am presenting this case is that this actually in a jinx, you can actually describe the whole management options in avascular necrosis. So you can see that once the head is collapsed, you can't salvage or you can preserve the femoral head. You need to go for a replacement options like a total hip replacement. And when the head is not collapsed, it is just that the necrotic segment has formed and the head is not collapsed, then you can preserve the head. So here what I have done is in a nutshell, it is a fibula strut allograft, that is a fibular graft taken from another person, cadaveric bone, and person's own BMAC, bone marrow aspirate concentrate, and the patient's own cancellous bone from the other head. There are other procedures that you can, as I told you, just the core decompression, simple procedure, multiple holes into the sclerotic cavity. Some people do that. Some people do bone graft through a window through the neck. You make a small window through the neck and you fill in the bone graft chip into the cavity. Then there is something called as a trapdoor procedure, where you make a window into the cartilage onto the femoral head, make a trapdoor and fill in the cavity from there. And then there are some procedures that is described like tandalum rods, that actually you put a rod into a very biocompatible rod into the sclerotic region to fill in that area. But those things have already gone out of the thing. Another thing that you can do to salvage the head, which is not very common in India, mostly described in Japan, is rotational or valgus varus osteotomy, where if the necrotic bone is on the top of the femoral head, you rotate the femoral, you make an osteotomy, a surgical cut, rotate the head and take the weight bearing portion away from that. So in that way also we can preserve the femoral head. So these are the
Very interesting, doctor. How is the patient doing now? How fast has he got rehabilitated to his normal work?
Absolutely. So basically, is it a sure shot procedure? I have to say it is not. You cannot guarantee that head preserving surgeries always work. But there are certain things that indicates that you should do it. So as I told you, my patient was 24-year-old patient. So how much of a good total hip replacement that you do, it will last. So the best hands, it will last around 25 to 30 years max. So this one, the patient, by the time he is 45, 50, he has to go for a revision total hip replacement. And revision total hip or total knee replacement is not like changing the car tires. It is a much bigger surgery. When you take out the implant, a lot of host bone will be removed and you have to use special and bigger and much larger implants to do a revision surgery. So as the patient is young, even if there is a borderline indication, you should try to preserve the head. So another thing is head preserving surgeries are mostly done for reversible causes. Let me talk about a bit of what causes AVN. So the AVN is mainly, most of the medical students are familiar with a big list of medical causes for AVN. But the interesting fact is that out of this 30, 35 causes listed, the interesting fact is that more than 95% cases of avascular necrosis of the femoral head is caused by 4 conditions. One is long-term steroid use, which can be anabolic steroid abuse or medical treatment for for medical conditions for long-term thing. That is number one. Number two is alcohol use. It is interesting to note that not the quantity of alcohol is not the important thing, but the duration and frequency of alcohol intake determines the avascular necrosis developing chance. The third cause will be trauma. That means any injuries around the hip joint. That is like a dislocated hip joint or fractures around the hip joint that can interrupt the blood supply. And the fourth cause, we call it as idiopathic. It accounts for about 30% of cases where the cause is not known. So all the rest of the 35 causes that we learn in medical textbook, it only contributes to around 2 to 3%. One of the factors that determines whether the head preserving surgery will work is the whether the etiology is reversible or not. If the AVN is caused by trauma, it is a permanent damage. It is highly unlikely that we can return the blood supply and osteogenic potential to that necrotic region. But something like alcohol use where we can stop it, or steroid use, conditions we can stop it, the chances of recovery is more. Another thing that determines whether we can preserve the head or sacrifice the head is the size of the lesion. So basically, if a large size lesion, salvage might not be possible. It is said that more than 60% of the head involvement, it is highly unlikely that we can salvage. Or the other one is the location. If it is right on the weight-bearing region of the femoral head, that is on the top superior aspect of the femoral head, chances of collapse is more. But still, you can always try. And the most important thing, as I told you, is the age of the patient. A 24-year-old gentleman, always try for preserving the head, even if the chances are not that high that we can save it. Give it a chance.
So selection of patient is very, very critical for better outcomes.
Absolutely. Yeah. That is the key.
Yeah.
So
some blood disorders also can contribute to AVN, doctor?
Yeah. So basically, the pathophysiology of AVN is very varied. So like when we go for FRCS exam or our MS exam, so basically you have to have nobody actually really knows what exactly happens there. But you should be, they will definitely ask you, especially because of this thing, they will ask you what exactly happens. So you should be ready with your answer, So you cannot just be mum in that particular scenario. So basically what happens is, as I mentioned, one, intraosseous hypertension. There can be microemboli, like, you block the blood supply to the area. Sometimes there can be venous stasis. The venous outflow can be obstruction, or can be extraosseous. Like in a trauma, the outside blood supply can be obstructed. So there are. It's a very confusing thing, and nobody really knows why AVN happens.
The next question I want to ask you, doctor, is on the diagnosis of AVN. As you said, if it is the early symptoms are mild, how do these patients present to you?
Absolutely. So it is very, very interesting. So most of these patients are, as I told you before, are young patients. So mostly very active in their prime of their life. They are like, they are working, likely a working, young, active gentleman comes with a deep-seated pain in the groin region. He usually will think, like any of us will think that, oh, I have just sprained it, or one of the muscles have snapped. And he probably will have this pain only on extremes of activity, on prolonged standing, or prolonged walking, or climbing up and down stairs, sitting on the ground. He will only have the symptoms on certain activities. He will just live with it for a long time. He will live with that pain. The pain becomes more and more, and it actually affects its day-to-day activities more, and the pain becomes constant, and his movements of the hip also gets affected. Later on, sometimes the other hip also started aching, because it is, as I told you, it's a bilateral condition, not as simultaneously starting, but one after the other within a few months gap in most of the cases. So the other hip also can present. You can, when you question the patient, you can find out the etiological factors of steroid use, alcohol, even smoking also is affected. Then you can ask about childhood or recent onset of trauma, and then there is a whole list of SLE, as you told, blood dyscrasia as like sickle cell disease and hyperlipidemia and the whole note, radiation. And in exams you will get all these rare causes, like I had this cancer of my brain and now I have got pain in the hip, so he had radiation and he has developed this. So there will be some funny things in exams, all the rare things come out during exams. So this is the main causes, these are type of presentations. And on examination, you can, like when you press on the hip, there will be pain deep in the hip joint. The movements, especially flexion, abduction, and internal rotation, will be limited in the hip joint. And obviously, young patient with this, like I will have a very low threshold of doing some investigations in this patient.
So what investigation do you start with? Is X-ray
Yes.
the first? Yeah.
Yes. So basically, like in any orthopedic condition, the basic investigation is X-ray. Although we don't think of finding anything, always do an X-ray for this condition, and you will pick up a lot of things. So in case of avascular necrosis of the femoral head, every patient, if you suspect this condition, the patient goes for a pelvis with both hips X-ray and a frog lateral view X-ray. That's two views of both the hips. Then in the X-ray, in AVN, the findings will be, the early stage X-ray will be normal. And later on, slowly the X-ray changes will start developing. That is, the bone density increases in that necrotic segment of the femoral head. Then later on, you can see increased bone density mixed with bone lysis, that is dark and white patches on that necrotic segment. Later on, it becomes a whole cavitatory kind of a lesion. The area will become necrosed, and in the end stage, it collapses and develops and goes into both the cup and the ball gets arthritis. So that is the X-ray findings. The investigation of choice in avascular necrosis, especially in the early stage, have a very low threshold of ordering an MRI if you suspect AVN. So basically, in cases where we don't pick up AVN on X-rays, MRI is 70 to 100% sensitive in picking up AVN cases. So here it can in both the views of MRI, it can be either as hyper intense or hypo intense lesions on MRI scan. I would also like to mention there are two other modalities not very commonly used. One is CT scan. CT scan can detect subtle fractures of the bone better than MRI. You can see a small fracture that actually tilts your decision making. Once the fracture has occurred, preservation is not a very suitable procedure. Although desirable, it's not a very suitable procedure. So CT scan has got a limited role. It can better pick up fractures of the necrotic segment. The last imaging modality will be a bone scan. So there are certain patients who cannot go for an MRI. Like there are contraindications for going for MRI, like metal coils in the brain and like some kind of pacemakers, all type of stents and all those kind of things. So those patients, as a corroboratory evidence, you can give a bone scan with an X-ray can suffice with obviously with a CT scan if you cannot do an MRI. Or in certain cases, the MRI findings can be equivocal and we want more evidence that what is happening. In bone scan, you can see increased pickup of the dye in the early stages, and later on it becomes like a cold spot on a bone scan.
So after you do the diagnosis, do we have some mapping to find out at what stage of AVN these patients are?
Absolutely. So if you ask me, staging or classifying the progress of the AVN determines the treatment. So basically, like the most simplest and the most commonly known classification system in avascular necrosis of the femoral head is called as the Fickett and Arlett classification. This is an X-ray based classification. It is classified into 4 stages, stage 1 to stage 4. Stage 1, the X-ray is normal. In stage 2, there is sclerosis, but no head has not collapsed. In stage 3, the head has fractured and the necrotic segment has collapsed. And stage 4 is the full arthritis. So the whole your decision making in management depends on these stages.
So after you have staged the patient, the next is going to be the treatment. So can you throw some light on the treatment methods, methodology?
Absolutely. So basically, management in AVN can be conservative or surgical or operative. Conservative has got 2 limbs. One is physical and one is pharmacological. So physical conservative measures include activity modification, that is limiting weight bearing with walking aids, physiotherapy to the hip, that is muscle strengthening, pain management for the patient, and certain like experimental things like ultrasound and shock wave therapy and hyperbaric oxygen therapy to the head to improve the vascularity. The second one is the pharmacological management, the conservative pharmacological management. The drugs that we try are bisphosphonates, which improves the bone stock. The second one will be like statins, that is lipid lowering agents that one of the etiology described, as I told you, the confusing etiology will be, or the pathogenesis is increased the lipids in the circulation, clogging the circulation. So statin has been used, and blood thinners, that some other, as you told about the hemoglobinopathies, blood clots have been told to produce AVN. So blood thinners and anticoagulants has been used as a pharmacological conservative management. Coming on to the surgical management, if you ask me, conservative management is at the best experimental or adjunct. So basically adjunct to a surgical management. I don't solely depend on like conservative management in any of my patients. But if you think, if some people want to try it, you can try it in small lesions, less than 30% lesion, stage 1 disease, or a non-weight bearing region of the femoral head, you can try that. But most of the AVN, especially once it becomes stage 2, the management will be operative. Operative management are 2 types. One is head preserving surgeries, and the second one is head sacrificing surgeries. Head preserving surgeries, like this is why I started off with that case where on one side it is head preservation and the other side is head sacrificing, which is the total hip replacement. Let us keep total hip replacement to one side. Let us talk about the head preserving surgeries. The basic and the most common head preserving surgeries is core decompression, where the surgeon put multiple small drill holes into the center of the necrotic cavities to de-stress the increased tension inside the bone. So that is a very simple procedure. It doesn't take much time. You put the patient on the fracture table, multiple 2 mm, 3 mm drill holes, you fire into the cavity, you are done with that. So whether it works, very debatable, like the literature is very varied on that. I personally don't believe in just doing core decompression alone. I believe in removing the whole of the necrotic bone, do a larger core into the to the cavity, remove all the necrotic bone, remove the all the dead tissue and the cavitatory tissue and all the lining of the sclerotic cavity, remove everything with some method, and then fill it with osteoinductive and osteogenic potential substance, biologics, into the cavity. In my case, I did the cancellous bone graft taken from the other hip, which is, as I told you, it is called as the red gold. That is, it is the best osteogenic thing that you can put it to fill in the cavity, and to augment it, we use the BMAC, and to support it, we put the fibula strut into the cavity. You have to be innovative when you deal with head preserving surgeries. So after I have come back from Singapore, you don't get fibula strut allograft here. BMAC is on the expensive side. It costs around 50K like cost. Then you don't do combined surgeries, like you don't do one side hip replacement, you don't get bone graft from the other side head. So in those kind of situations, few cases that I have done, I had one patient recently done around say about 3 to 4 months back, young gentleman, 29-year-old gentleman presenting with bilateral hip pain, very thin, like very healthy guy, like very ambitious guy. So basically head has not collapsed both sides. So I was planning for taking BMAC. BMAC is not that costly per se. So basically he could afford that. So we bone marrow we aspirated from the iliac crust. I made a small window on top of the iliac crust, scooped out bone from that from the iliac crust of one side, very limited bone. Then what I did was harvested his own fibula from one side. To my surprise, his fibula was very, very thick. It was almost like coming to around about 14 to 15 centimeter in thickness in one dimension. So I split that fibula and used it in both on one side. Split it longitudinally, put iliac crust bone graft and BMAC into both the hips after preparing the tunnel, and the split fibula from his own body was put it as a strut support all the way into the to the cavity. I can actually show those pictures, the end pictures. This particular patient, after say non-weight bearing, he is wheelchair for about 3 weeks to 4 weeks, because there is a big say about 8 hole into his head, and we can't weight bear straight away. So at present he is walking about 3 months plus. He is walking. The bone grafts have incorporated, and he is walking now. Hopefully, whether it will work, we don't know. We need to wait for the result. Another case, this particular lady cannot afford any surgical procedures. BMAC cannot afford. So basically took bone graft from a iliac crust, one-sided lesion, stage 2, no collapse. So took her fibula strut, filled her cavity with the iliac crust bone chips, and put her fibula in for support. Touch wood, she is around say about 2 years after surgery. She is doing well. If you can give say about 10 years, 15 years life to that femoral head, then we can obviously do your replacement surgery, where one surgery can take her throughout her life.
Coming over to implants, doctor, what we would like to know, what kind of surgeries you do for total hip replacement, and what implants you use and what technique you use.
Okay, so avascular necrosis of the femoral head is a very unique situation, where we have this hip arthritis in a very vibrant, young, active, working person. So this, if you are forced to do a total hip replacement, the most important thing is to give longevity to the implant. So what is most important in longevity? Longevity, I would say, do the surgery properly. Don't do the surgery if you do less than say 15 or 20 replacement surgeries, less than that per year. Leave it to a specialist. It has to be done properly. You have to put your acetabular cup in the native position, in the correct position. You have to put your femoral stem in the exact position. You have to reproduce the biomechanics of the hip. That means you have to maintain something called as the offset. That means the distance between the femoral head center and the femoral shaft, that decides the tension of the soft tissues. You have to maintain your leg length. That means after doing the surgery, other than improving the tension, you should have equal leg lengths, and you should fix your implants properly in both the acetabulum and in the femoral head, in whichever philosophy that you think you have to fix it properly. So do a proper job, get your angles perfect. Don't load different areas of the implants differentially, like edge loading and increasing the wear. And obviously use the best implants available. You basically the implants with better wear properties, better friction profile, better lubrication, all those kind of properties. There are different materials that move in the hip joint, like from the cup and in the head. The conventional one will be metal on polyethylene, metal on plastic, which probably will not be the best thing to use in a young gentleman. There is the best kind of wear properties is between ceramic and ceramic articulation, where the inner part of the cup and the head will be ceramic, but it has to be done by an expert. If you get your angles wrong in your cup, it can lead on to edge loading and it can lead on to failure. But if you do it perfect, it might last much more than any other articulation. A safe bet will be, in most of the hands, will be a polyethylene with a ceramic articulation, which has got a wear properties and a wear rate between these two kind of both the articulation. So that is something that we have to keep in mind when we do total hip replacement in younger individuals.
Dr. Last 2-3 questions. Is there a new approach or a philosophy coming up in hip surgery? We hear of a lot of anterior approach these days. What are your thoughts on that?
Okay, so anything new, you try it. Definitely, you try it. I have tried it. So anterior approach is it's a very informed field now. I personally feel that with regards to anterior approach, the learning curve is a bit too steep. You definitely struggle with your first 5 to 10 cases. You release much more than what is described by the experts in the field. But once you master that field, it is a very robust approach. It is called as a muscle sparing approach, and it cuts away much less. But your learning curve is a bit steep, and you have to be really dedicated if you think that to being an anterior hip surgeon.
But from the patient standpoint, it is definitely
It is something that worth mentioning. Some old timers will say that all the other things works with me, then why should I venture into something new? But if you want to explore it, anterior approach is something worth trying. It has got its own advantages.
Doctor, on the technology front, how much is robotics of use in hip replacement and hip surgeries?
Yeah. So basically, if you ask me about innovation and technology, it is important, but the surgeon is the most important person, determining the outcome of that particular surgical approach. So you should have compassion. You should know your patient. You should know the patient's condition. You should know the patient's life, your expectations of the patient. You should know the lifestyle of the patient. You should know the patient and the condition as a whole. You should also know your stuff, what is that particular condition, what does it involve, what is the normal, what is the goals of you performing a procedure. So your long-term results, purely robotics definitely helps in placing an implant. It also has got a long learning curve. Some studies have shown about 50 cases to get the optimal results. But for me, the most important thing is the surgeon who is compassionate, who is knowledgeable, who is skilled to execute that particular procedure.
From the patient standpoint, at what stage of the pain or what stage of their movements they should consult you or any other doctor?
Right. So if you ask me, any pain, just give it a week. Nothing more. Especially in case of hip pain in young person, like most people will attribute this pain to some injury that occurred, which is actually just a false linkage. They will contribute it that it because of I climbed a big step, I had this pain. But in reality, especially in case of AVN, like people sit on this pain much too longer for comfort, and you end up doing like head sacrificing procedures.
So, under Dr. Project Heal, we also, this is the last question, we would like to understand how do we prevent, if there is any preventable ways of AVN or any hip problems? What are those preventive methods?
Okay, so for AVN, like you have to look at the causative factors: alcohol, smoking, two vices. Like as I told you, like smoking, it's the number of sticks that you do, and for alcohol, it is the longevity of the thing. Even some studies have shown that even small amounts of alcohol for a longer period of time can contribute to AVN. So anything, steroid use, be very like especially abuse of steroids like anabolic steroids in like bodybuilders and sports persons. That should be that is a definite no. So maintain your healthy lifestyle and consult a doctor, especially if your hip pain or your groin pain lasts for more than a week.
Do we have any correlation between diabetes and AVN or hip problems? Nothing.
No, diabetes is not have any association with AVN.
Okay, doctor, we started with the notion that hip problems are basically a disease of the aged, old people. But Dr. Jikku threw light into how the younger population also have started getting AVN. AVN is a very common cause for many hip problems. But what is AVN and what are the causes? What is the treatment? How do we diagnose it? At what stage should somebody who has got a problem see a patient? Dr. Jikku explained us at length about all these things. It was a very fruitful interaction with Dr. Jikku. Thank you very much for educating the patients and the doctors on the hip problems prevalent in India. Thank you very much, Dr. Jikku.
Thank you, Mohan, for the opportunity. Thank you.